Do we have any participants? Hello everyone, I'm Dr. Rohit Prakara. So in this session, we'll be discussing certain aspects of Parkinson's disease. I'm a neurologist practicing in the city of Visakhapatnam, and I'm a faculty of neurology for Prakara. So today we'll have a detailed account of what Parkinson's disease is, what are the clinical features, what causes it, and how do we treat this disease. So Parkinson's disease was first described in the year 1817 by James Parkinson. Uh, it was such a beautiful description. He summarized the entire clinical features of Parkinson's disease in these two, three lines. So let us go through that. Each word here is important because it describes very important clinical features that are associated with Parkinson's disease. So James Parkinson described it as involuntary tremulous motion with lessened muscular power in parts not in action and even when supported, with a propensity to bend the trunk forward and to pass from a walking to a running pace, the senses and intellects being uninjured. So what this tells us is that basically it's a movement disorder causing involuntary movements, and especially these movements occur when the limb is at rest. At the same time, the muscle power is not reduced. That means the power or the ability to perform motor activity in terms of power is not reduced, but it is only the movement disorder which is the cardinal feature here. At the same time, there are other trunkal features like bending of the trunk, and then when he says that the patient passes from a walking to a running pace, it describes the typical festinating gait of these patients, and the senses and intellects being uninjured. That means the cognitive abilities of the patient are relatively preserved, towards even the later stages of the disease. So the incidence of Parkinson's disease is nearly 60,000 per year. This is worldwide incidence. It increases with age. Around 3% of population beyond 65 years are affected with Parkinson's disease. The mean age at onset is around 6th to 7th decade. It is slightly more common in men when compared to women, and 85% patients are over 65 years. So what is Parkinsonism? What is Parkinson disease? Basically, Parkinsonism is a syndrome that is manifested by rest tremor, rigidity, bradykinesia, and postural instability. So Parkinsonism is a broad syndrome, broad spectrum of clinical features, which includes the four features that I've mentioned. And there can be many causes of Parkinsonism, where idiopathic Parkinson disease, which is also known as Parkinson disease, is the commonest of those causes. So Parkinsonism can be caused by idiopathic Parkinson disease, or it could be caused by Parkinson plus syndromes. The common examples here are multisystem atrophy or progressive supranuclear palsy, or it could be Lewy body dementia, or sometimes it could be drug-induced Parkinsonism, or there are various other causes which can lead to Parkinsonism. But the most common cause of all these is the idiopathic Parkinson disease. So apart from idiopathic Parkinson's, we have atherosclerotic disease, which is predominantly the vascular Parkinsonism, or it could be post-encephalitic. A patient who had encephalitis can later on develop Parkinsonism. This is commonly seen in Japanese encephalitis. Or sometimes it could be post-trauma, post-traumatic brain injury, post-concussion also, patients can develop Parkinsonism. Or patients with Wilson disease, the one of the commonest genetic causes of Parkinsonism being Wilson's disease. or carbon monoxide poisoning, or MPTP poisoning, or manganese dust intoxication also can lead to Parkinsonism. Some other rare causes of Parkinson's disease are neurosyphilis. Neurosyphilis used to be prevalent a few decades ago, but later on, the prevalence of syphilis has come down due to availability of good antibiotics. But of late, we have seen a resurgence in cases of neurosyphilis where they can present with Parkinsonism or movement disorders. Or another common condition that we come across is drug-induced Parkinsonism. Anti-dopaminergic drugs, mainly the anti-emetics or the prokinetic drugs that are used. For example, metoclopramide or levosulpiride, which are commonly used for acid peptic disease or gastritis. These drugs also can cause Parkinsonism. Or some antipsychotic drugs also are known to cause Parkinsonism. Then rarely it could be a brain tumor affecting the basal ganglia that also can lead to Parkinson disease. Another genetic condition similar to Wilson disease is Huntington disease. Huntington disease is usually seen in the elderly, but sometimes there is a phenomenon called anticipation where in the later generations, in the subsequent generations, the age of onset is advanced. So even young patients start developing Huntington's disease, and these patients most commonly present with Parkinsonism. While the usual common presentation of Huntington disease is chorea, young onset Huntington disease can present with Parkinsonism. So, what is the pathology? What happens inside the cell, inside the brain, leading to such a debilitating disease? Is the main pathophysiology is depigmentation of cells, subsequently leading to neuronal loss and ultimately ending up in gliosis. So the commonest or the most important parts that are involved are substantia nigra pars compacta, which is part of the mesencephalon, or it could be pontine locus ceruleus, or the dorsal nucleus of vagus. It can be, see, initially only one of these areas or some of these areas can be involved, but then later on it spreads and multiple areas of the brain get involved. But the predominant areas that one should remember are substantia nigra pars compacta, pontine locus ceruleus, and dorsal nucleus of vagus. So what happens in these cells is basically there is accumulation of pathogenic bodies called Lewy bodies. These are the pathological hallmark of Parkinson disease. They are round eosinophilic intracytoplasmic inclusion bodies. They have a dense granular core and a peripheral halo. They're made up of alpha-synuclein and ubiquitin. These Lewy bodies are not exclusive to Parkinson disease, but they are hallmark of Parkinson disease. They are also seen in other conditions like uh, neurodegeneration with brain iron accumulation, or progressive supranuclear palsy, or corticobasal degeneration, or sometimes even in Alzheimer's disease. That's why we tend to see some overlap between patients with Alzheimer's disease and Parkinson disease. Patients with Parkinson disease may have memory impairment. Similarly, Alzheimer's disease patients also can sometimes show Parkinsonian symptoms. So if you see in this, the image on the top right is that's of a normal mesencephalon, where you see there is a pigmentation there. When you compare it to the one on the right side, that pigment is absent. So that is what we mean by depigmentation. Basically, there is in substantia nigra pars compacta, there is loss of pigment. This leads to this is where the pathogenesis starts in Parkinson disease, and then later on it spreads to the other areas of the brain as well. And in the below slides, the histopath, you see there is loss of pigmented cells, and the number of cells are also reduced. And then you can see Lewy bodies in the bottom right slide, which are dense intracytoplasmic inclusion bodies with a central pigmentation and then a peripheral halo. So as I was saying, basically it starts in some areas and then it progresses to involve the other structures in the brain. Based on that, Braque proposed a staging method, or basically the way it progresses from one area to the other. So this proposed staging includes stages 1 and 2, where only medulla oblongata and olfactory bulb are involved, and stages 3 and 4, where substantia nigra, pars compacta, midbrain, and basal forebrain are involved. And in the advanced stages 5 and 6, even the cortex, basically the temporal and the frontal lobe, frontal cortices are also involved. So if you see, interestingly, in stages 1 and 2, there is a structure called olfactory bulb. So olfactory bulb and medulla oblongata. Olfactory bulb seems to be the earlier involved structure in the brain. So this explains why patients with Parkinson disease develop anosmia even before developing any of their motor manifestations. So they tend to lose their loss of smell. This could be a prodromal symptom. That is, patients can start with this symptom. They can live for years together with this, only later on that they develop motor manifestations. Similarly, medulla oblongata is a structure which is responsible for reticular activating system. That is the system that controls our sleep. So these patients can have sleep disturbances also, which can manifest years before they develop motor manifestations. Once they reach stages 3 and 4, you have the typical motor manifestations. And when they reach stages 5 and 6, they can also have certain cognitive impairment. So the process starts from medulla and it progresses rostrally to the cerebral cortex. So what is the pathogenesis? The main pathogenic mechanisms are protein misfolding, aggregation, and cellular toxicity. This leads to defective proteolysis, mitochondrial dysfunction, and then leading to oxidative stress. And then the iron metabolism also becomes defective. And then later on, the immunological and inflammatory mechanisms are also activated, leading to cell loss, neuronal cell loss, and then ultimately ending up in gliosis. So what are basal ganglia? Basically, see, basal ganglia are those structures you can consider them as a connection between the cortex and the brainstem. So all the fibers that originate in the cortex, they have to reach the brainstem, and from there they go to the spinal cord and supply various muscles of the body. So these structures act as a conduit for those cortical fibers. So you can imagine basal ganglia to be either facilitators or inhibitors of movement. What it means is that basal ganglia do not generate movement. The movement is generated in the cortex, probably the motor cortex or the supplementary motor cortex, where the idea or the initiation of movement happens. But then what basal ganglia do is that they tend to fine tune these movements. They either facilitate movement or they inhibit movement. So they act as a control mechanism for movements. So when there is problem with facilitation of movement, what happens is there is decreased movement. That leads to hypokinetic movement disorders. And when there is problem with uh, inhibition of movement, there is excess movement in the body. That leads to hyperkinetic movement disorders. So if you look at the examples of classical example of hypokinetic movement disorder is Parkinson disease. Whereas examples of hyperkinetic movement disorders are chorea, balismus, athetosis, or various other movement disorders like myoclonus or even tremors for that matter. So which are the important basal ganglia structures that are involved in these movement disorders? They are caudate nucleus, putamen, globus pallidus, which again has two parts, globus pallidus internus and externus, and then subthalamic nuclei, substantia nigra, and a part of thalamus also, which is the mediodorsal and ventromedial nuclei of thalamus. So caudate nucleus and putamen together are known as corpus striatum. So looking into the pathophysiology of various movement disorders, the don't get confused or perplexed by this chart. See, the what basically happens in a normal individual is that the idea of movement is generated in the cortex, and the basal ganglia, they facilitate movement and control the movement. So for accuracy and precision of movement, they either inhibit certain parts or they facilitate movement in certain parts. So the most important structures that are associated with this task, that are given this task, are putamen, substantia nigra, globus pallidus, subthalamic nucleus, and ventrolateral nucleus of thalamus. So in a normal individual, there is adequate facilitation and inhibition causing accurate movement. Whereas if you see in Parkinson disease, what happens is there is loss of facilitation. The structures which cause facilitation of movement are impaired. For example, the substantia nigra pars compacta in PD. So then what happens is that there is inhibition of movement. So because there is lack of facilitation, there is inhibition leading to hypokinetic features. Whereas in a hyperkinetic movement disorder like dyskinesia, the inhibitory mechanisms are impaired here. The structures which cause inhibition of excessive movement, they are impaired, and that leads to hyperkinetic movement disorder. That is, there is excess of movement, which is abnormal. So try to remember these basic two categories of hypokinetic and hyperkinetic movement disorders, and how these basal ganglia either facilitate or inhibit movement. So the beauty of human body is that whenever there is a disease, the body tries to tackle it with some compensatory mechanisms. Similarly, in Parkinson disease also, there are certain compensatory mechanisms, like there is increased synthesis of dopamine in whatever neurons are surviving, and there can be increased afferents to dendrites of dopaminergic neurons, or there can be proliferation of dopaminergic receptors, and there is sometimes downregulation of dopamine transporter, so that excess more of dopamine is available at the nerve endings. As long as these compensatory mechanisms are functional and are able to control the disease, the patient may not develop any manifestations. But once the disease progresses after a certain stage, even these compensatory mechanisms fail to stop the patient from developing these symptoms. That is when the disease surfaces and the patient presents to us. So when the stages of compensation cross a certain threshold, then probably the patient starts developing symptoms, and that's when we start seeing them. Parkinson disease usually sporadic, but rarely it could be genetic as well. There are certain genes that are strongly linked to developing genetic Parkinson disease, like the SNCA or the LRRK2 or Parkin gene or Pink gene or DJ1 gene. So these are all well-established causes. There are many families and cohorts of patients worldwide where the Parkinsonism runs in families, and then their clinical features are slightly different from the sporadic idiopathic Parkinson disease patients. So Parkinson disease can be sporadic, or it can be inherited in the form of autosomal dominant inheritance or autosomal recessive inheritance also. So let us discuss certain associated factors. Like, these are not causative, but they can be associated with Parkinson disease. So the protective factors that have been found to prevent the development or probably less associated with Parkinson disease patients are caffeine consumption. So moderate amount of caffeine consumption has been found to be slightly protective against development of Parkinson disease. And patients who are physically active, in them the incidence of Parkinson disease seems to be less. And for some strange reason, smoking also, patients who smoke are found to, the incidence of Parkinson disease in them is found to be less, but that does not mean we should start smoking, because the risk factors or the adverse effects of smoking are far worse when compared to this slight protective association. More importantly, what are the risk factors for developing Parkinson disease? Head trauma, vitamin D deficiency, developing migraine in midlife, individuals who are living in heavily industrialized areas, individuals living in rural areas who are predominantly based on farming and agriculture, and individuals who consume well water, or individuals who have excessive body weight. All these are found to be associated risk factors for developing Parkinson disease. So let us discuss some of the clinical features in detail. So the most common, the clinical features of Parkinson disease, or the most prominent clinical features, are the motor manifestations, because they are very obvious and these are very debilitating. So the patients most often present to us with these motor manifestations. But there can be certain non-motor manifestations also, which are sort of less recognized, but they can be more or equally debilitating, and they tend to occur early than the motor manifestations. So once we identify them, we have a window where we can diagnose these patients early and probably treat them better even before they start developing any symptoms. Excuse me. So the cardinal features of idiopathic Parkinson disease are bradykinesia, rigidity, resting tremor, and postural instability. In addition to that, they can have certain other manifestations like stoop posture, masked faces, or reduced arm swing, slightly flexed hip and knees, and they can have a shuffling gait, short step shuffling gait, and tremors in the hands or legs. So how does the tremor in a patient with Parkinson disease behave? See, basically, tremors are classified based on whether they occur at rest or in action. So, in Parkinson disease, the cardinal feature is rest tremor. So, when the patient rests their arms or hands, that is when they start developing tremors. The classical tremor in Parkinson disease is the pill rolling tremor. This is basically because both the thumb and the index finger, they have tremor at a time. So, it looks like the patient is trying to roll a pill. So this is the typical pill rolling tremor that is seen in Parkinson disease patients, and it occurs at rest. So when the patient is doing some activity, it may not be very obvious, but when the hand rests, they start having this tremor. This is in early stages, but in once the disease progresses, they can also have some tremor component in action as well. And how do we check this in patients? So we just ask them to stretch their hands, and then we wait for a moment when they before they start developing this tremor. This is how a typical Parkinson disease tremor is seen. So it can start in hands. That is that is what we commonly see, but it can start in legs also, and rarely it can happen in the head, or there can be jaw tremor also. So it occurs at rest and it is diminished on action. And when distracted, it tends to get more intense. So it's a coarse pill rolling tremor. Tremor is always a rhythmic movement, rhythmic to and fro movement occurring at any particular joint. And the usual frequency is 2 to 6 hertz. That is, it is one of the slower tremors. So that the frequency, that is, there will be 2 to 6 tremors per second. So it could be like this. And the most commonly involved ones are the hands, but then it can be seen in feet, jaw, lips, and even pharynx. When patients have that pharyngeal tremor, they typically have an undulating voice. They have voice tremor. They cannot the voice becomes unstable and the voice tremor is obvious. So, but sometimes there can be fluctuations in amplitude, but not frequency. And another typical feature in these patients is that the tremor, because it's an involuntary movement, it is absent when the patient is asleep. So only when the patient is awake, you see these tremors. Coming to rigidity, what is rigidity? Rigidity is increased tone, basically increased tone across the joint. So there is passive resistance to passive movement, and the patient perceives it as stiffness. Most of the patients perceive it as stiffness. Some patients can complain it as heaviness of the limb also. But then ultimately what it does is that it does not let them use their limb as freely and as fluidly as possible as earlier. So it could lead to cogwheel rigidity in the upper limbs. Basically, the rigidity, as we know, is increased tone. So there is difficulty, there is increased tone in these movements. Cogwheel rigidity is usually checked at the wrist. So when we look for rigidity, when we look for tone around the wrist, what happens is there is the tone is interrupted by a tremor. So that's when it feels like a cog wheel. So there is frequent interruption at the rhythmic interruption at the wrist while we are passively moving it. So that is perceived as cog wheel rigidity. In the lower limbs, it feels like lead pipe rigidity, which is uniform rigidity. The leg starts feeling like a log. You find it, the patient finds it difficult to flex or bend, and the examiner also finds it difficult. Or rigidity can also manifest as a flexed posture. When there is truncal rigidity, the posture also changes and there can be flexion. So rigidity principally affects axial muscles, and it predominantly affects the proximal and flexor group of muscles. So cogwheel rigidity is also known as Negro's sign. Rigidity is present throughout the range of movement without the ebb at extremes of range. So this increased tone at the extremes of range is classical of spasticity. So that's how we differentiate spasticity from rigidity, because rigidity is present throughout the range of movement without any increase towards the end of movement. The next clinical feature is bradykinesia. What does bradykinesia mean? Bradykinesia can mean uh, decreased movement or less movement, basically. That means there can be decrease in amplitude of movement, or there can be decrease in quantity of movement also. So how does it manifest? It manifests as difficulty in initiating movement, or poor rapid fine movements. Basically, the patient cannot do any rapid movements. So that is a way in which bradykinesia manifests. In the face, it could be hypomimia, that is lack of facial expressions. In a normal patient, no, in a normal individual, when we usually see associated facial expressions, right, when we are conversing. So that is lost in Parkinson disease, and these patients have hypomimia. In addition, another manifestation, another way bradykinesia manifests is that there is reduced spontaneous blinking. So the blink rate, which is normally at least 12 per minute in normal individuals, is reduced in Parkinson disease patients. So how do we check for bradykinesia? One thing is we need to observe them when the patient walks into the room. We need to observe them for bradykinesia. We need to look at their face and see if the associated clinical features, associated facial expressions are there or not. And there can be reduced movements in the arms when the patient is walking, the arm swing is reduced. Or there is a simple test. There are certain simple tests that we do to bring out bradykinesia. For example, finger tapping. We ask the patient to do rapid finger tapping. So if a normal individual does like this, a patient with Parkinson disease will not be able to do it. So what happens is, in some patients, the range of movement comes down. So they may start doing this, but slowly what happens is that the range of movement comes down. Or sometimes the speed of movement also is low. So if a normal individual can do this, a patient with Parkinson disease may be able to do only at this pace. Or there is a test called arm roll test also. So we ask them to roll their arms, and Parkinson disease patients usually are not able to do this. So paucity and slowing of movements can be there. There can be loss of associated movements. The most common example is reduced arm swing. In patients with Parkinson disease, because it starts unilaterally, one of the sides, the arm swing is reduced. Or there can be masking of the face, the infrequent smiling, there can be infrequent blinking, and there are certain phenomena that are rarely observed in Parkinson disease. Paralysis agitans is the term that was initially used to describe Parkinson disease. But in very few patients, we see a phenomenon called kinesia paradox. That means these individuals normally are not able to carry out their activities as fluidly or as freely, like normal individuals. But in certain conditions, when there are certain stimuli, they somehow suddenly start moving fast. So for example, there are accounts of patients who are advanced Parkinson disease patients who've been wheelchair bound for quite a few years. There are examples and accounts where they start running when they see fire. So a patient who was not able to walk till then, who was wheelchair bound, suddenly starts walking. So The exact pathophysiological mechanism of this is not known, but what is suggested is that there are certain alternate pathways that are involved in such cases. Like in addition to the traditional pathway that we just described involving the motor cortex, the basal ganglia, and the brainstem, there are certain other shortcuts probably where the fast movements are carried out. So that is the proposed mechanism. And then what happens is during such stimulation or certain emotional stimuli, or when the patient is subjected to some intense fear, these they start moving fast. Another example is that Parkinson disease patients with who have difficulty in walking, who are very slow to walk, they do well when they are playing certain sports. Some of the Parkinson disease patients can play badminton really well, but they cannot walk fast. The next cardinal feature of Parkinson disease is postural instability. Postural instability occurs because of loss of postural reflexes. So it can be in the form of a stoop posture, or it can be in late stages. What happens is that they start having recurrent falls. So they have difficulty in making turns, and sometimes they have retropulsion also. So postural instability arises from poor balance. They have a tendency to fall, but usually in Parkinson disease, it does not occur early in the course. Postural instability is something that develops slightly later in the course of the disease, maybe 5 to 10 years after the onset of symptoms. They tend to develop postural instability. But in certain diseases, certain Parkinson plus syndromes, for example, progressive supranuclear palsy, in those cases, this starts early, probably even within the first year of diagnosis itself. They can have postural instability and recurrent falls. Instability can also manifest as festinating gait. Festinating gait is hurried gait. So they are slow to start their walking, but after a few steps, they have, they are hasty. You find them hastily walking. So short step gait with fast pace is known as festinating gait. Some patients with advanced Parkinson disease can develop a simian posture. Simian posture, as we all know, is like apes basically. So they have their posture mimics that of an ape. So their trunk is flexed, their neck is flexed, and then their knees are flexed, and their arms are also flexed. So they assume a stoop posture, which leads to being described as simian posture. Some patients can have head drop and camptocormia also. Camptocormia is basically, again, the flexed posture which we see in Parkinson disease. When it is very severe, it is known as camptocormia. Some patients of Parkinson disease can have only lower half Parkinsonism, where the upper half, there are very few symptoms in the upper half of the body, while the lower half has uh, predominant symptoms. And then postural instability can lead to propulsion and retropulsion also. These patients can have recurrent falls either in the forward direction, which is called propulsion, or retropulsion in the backward direction. Retropulsion is very commonly seen in Parkinson disease, PSP, sorry, progressive supranuclear palsy, while propulsion is seen in other Parkinson plus syndromes. They can have hypomimia, they can have decreased blinking. There is a reptilian stare, that is because of reduced blink rate. Another common feature is micrographia. This could be a presenting manifestation of Parkinson disease. uh, I have seen quite a few patients who come to me saying that their handwriting has changed in the recent times. That is their only complaint. They don't have any other symptoms, and they are usually, otherwise they are normal. But their only symptom is that their handwriting has changed and the letters have become smaller than earlier. So when we test them thoroughly, when we do a thorough clinical examination, we might find some of the clinical features like rigidity or bradykinesia or postural instability. Postural instability at the bedside is tested by doing something called a pull test. We ask the patient to stand, and then we go behind the patient, and then we suddenly pull them. So a normal individual will be able to balance themselves and will not fall down, but a patient with postural instability will not be able to balance himself or herself, and then they take more than 3 steps backward, or they even sometimes fall on us. So that is how we test for postural instability in these patients. And some patients have a freezing phenomenon. That is, they have difficulty initiating movement. They when they start walking, it is very difficult for them to take the first few steps, or sometimes in the middle of walking also they suddenly freeze. They cannot walk. So that is called freezing phenomenon or freezing of gait. What are the other, once we have seen the cardinal features, what could be the associated features? There are many associated features. In these patients, when we examine them, their deep tendon reflexes are not impaired, they are preserved till the late stages. They have something called a striatal toe, which is basically dystonia, a dystonic posture in the toes. Or it could be Parkinsonian hand. Similar to striatal toe, they can have a striatal hand where the fingers are flexed and there is increased tone, and the patient assumes a posture similar to this. Or they can develop something called Meerson sign, which is also known as glabellar tap. This is basically a pathological reflex which is suppressed after birth, but then in Parkinson disease patient, this can resurface. When we tap them here from behind, uh, a normal individual does not close their eyes. So a patient with Parkinson disease who has this Meierson sign, they keep closing their eyes as many times as you tap. And another associated feature is anosmia. They can lose their sense of smell many years before developing motor manifestations, because as we've seen in the Braque staging, the olfactory bulb is the earliest stage. Olfactory bulb gets affected in stages 1 and 2 itself. So that's why they tend to develop anosmia. Some patients can develop constipation. Some develop sleep disturbances also, like sleep fragmentation. That is, they cannot sleep, have a sound sleep at a stretch. They have fragmented sleep, or some have rarely something called a REM sleep behavioral disorder. That is, when they are in deep sleep. That is, when they reach the REM sleep. Usually, REM sleep has associated atonia. We cannot move our limbs when we are in REM sleep, but this is impaired in patients with Parkinson disease. What they do is they start acting out their dreams. In the middle of dream, some patients start shouting, and some start flinging their arms and legs. So they injure the person sleeping beside them. So this is called REM behavioral disorder or REM sleep behavioral disorder. Another very common feature which is often neglected in Parkinson disease patients is depression. So it can present even decades before their motor manifestations start. So initially they are thought to be patients with depression, but later on they develop Parkinson disease. Only then we get to know that these patients initially in fact, had Parkinson disease, which started with depression. And sexual dysfunction is also a common feature in Parkinson disease patients. So what could be the first symptom in Parkinson disease? Is it always anosmia? No. Some patients may not develop anosmia. The most common feature with which the patients, Parkinson disease patients, present to us, and the starting symptom is tremor. In around 70% of patients with idiopathic Parkinson disease, tremor is the first manifestation and the most predominant manifestation. Similarly, they can have gait disturbances. Some present to us with stiffness, some present with slowness, and some patients present with just muscle pains. So vague muscle aches is a symptom with which they come to us, and it is, if that is the first symptom, it becomes very difficult for us to diagnose this disease, because they may not have developed other features. So something as vague as muscle aches, we cannot diagnose Parkinson disease in those patients. As I said, some patients present with handwriting disturbances, around 5% of patients. Around similar number of patients present to us with psychiatric manifestations, and some have speech disturbance. The speech disturbance in Parkinson disease is not like dysarthria, it is not slurred speech, but the hallmark of Parkinson disease speech is hypophonia. The tone or the volume of the speech comes down first. So the patient who used to speak loudly earlier, they start speaking very slowly. Or sometimes the pace of their speech also comes down. So that could be one of the presenting manifestations. So to revise all the clinical features of Parkinson disease, we have the cardinal motor features. that is bradykinesia, rest tremor, rigidity, and postural instability. Or they could have non-cardinal motor features like micrographia, that is the small handwriting, or masked faces, which is called hypomimia, or reduced eye blinking, or hypophonia, or dysphagia, or freezing of gait. Whereas the non-motor features could be anosmia, sensory disturbances, disorders, sleep disturbances, or autonomic disturbances. Parkinson disease patients can sometimes present to us with giddiness. And when we carefully check their blood pressure, they have orthostatic hypotension. Some have gastrointestinal disturbances like constipation. Some present only with sexual dysfunction. Or in late features or in rare cases, sometimes we even see cognitive impairment or frank dementia in such patients. So Parkinson disease patients, usually their cognition is intact and preserved till the late stages, but rarely Parkinson disease patients can also have dementia. Horn and Yar proposed the staging of Parkinson disease. This this becomes important when we have to document the stage of these patients, because, for example, a patient presents to you, a patient is with you for a while, and then after a certain period, the patient might go and present to some other healthcare provider. In such case, there should be a universal, uniform staging of Parkinson disease so that we get to understand if the patient's clinical course is improving, which is unlikely in Parkinson disease, or at least static, that it is not worsening fast, or whether it is rapidly worsening. So to know that, Hone and Yar have proposed a staging where in stage 1, the disease is usually unilateral, which is most common presentation of Parkinson disease. They can have either rigidity or tremor only in one half of their body, either left or right. In stage 2, it spreads to the other side. It can be asymmetrical, that is one side more than the other side, but it is bilateral. In stage 3, it is bilateral along with loss of balance, or that is postural instability also sets in. When there is postural instability, it becomes stage 3. And with all these, if there is significant disability in performing day-to-day activities, we call it stage 4. And in these stage 4 patients can sometimes be wheelchair bound. When the patient becomes bed bound completely, it is called stage 5. So how do we diagnose Parkinson disease? We discussed all the clinical features, right? So the all the essential clinical features, we need to take them into account, because Parkinson disease is a clinical diagnosis. So we need to make the diagnosis clinically. There is no single test that can detect Parkinson disease. It is the clinician who has to thoroughly take good history and then examine the patient, and that's how we diagnose Parkinson disease. There are certain things that can add to the diagnostic certainty of Parkinson disease, which is response to dopaminergic therapy. If you suspect Parkinson disease in a patient and then you give them dopaminergic drugs and the patient improves rapidly, that's a very strong indicator that your diagnosis is correct and the patient has Parkinson disease. And there should not be any other clinical features which suggest some other diagnosis. That means we need to rule out all other possible uh, conditions which Parkinson disease. Once we do that, there are certain tests that we can do which will help us again in confirming the diagnosis. For example, structural imaging like MRI, or we can do functional imaging like DAT scans. DAT scan is dopamine uptake. Basically, it's a test which measures the dopamine uptake. Or even FDG PET scan can be done, or sometimes olfactory and autonomic testing also. They are just ancillary, but they are not the only test that can give you uh, a substantial diagnostic certainty. Once we've diagnosed them, how do we treat them? The treatment includes pharmacological, surgical, as well as non-pharmacological options. So first, let us discuss certain drugs that we use in Parkinson disease. The most common drug that we use is levodopa along with carbidopa. Then there are other drugs like dopamine agonists also, for example, ropinirole or pramipexole. So how does levodopa act? Basically, levodopa restores the dopaminergic transmission by enhancing synthesis of dopamine in surviving neurons of substantia nigra. We add another molecule, that is carbidopa, to levodopa. This is to prevent peripheral decarboxylation of levodopa to dopamine. That means what happens is, see, in the first slide, if we administer levodopa, a lot of it is metabolized in the GI tract, and very little amount reaches the central nervous system. So this has two disadvantages. One is that the drug does not reach the central nervous system. The enough drug does not reach it. The second problem is, because it is metabolized in the GI tract, there are a lot of undesired side effects. So when we add carbidopa to this levodopa, what happens is that it prevents the peripheral decarboxylation of levodopa. So one advantage is that the side effects are minimal. And the second advantage is that more of dopamine is available in the neurons. So once dopa, as we all know, dopa is a precursor to dopamine. So we give levodopa along with carbidopa. So a lot of levodopa reaches the brain, and in the brain it is converted into dopamine. And this dopamine is available for the dopamine receptors. And when more receptors get activated with a lot of dopamine, we see that the patients with Parkinson disease start seeing improvement in their symptoms. There are certain disadvantages also. What happens is that see, the biggest disadvantage with levodopa is that the response to this drug is not consistent over time. So initially, when a patient in early Parkinson disease, when we give them this drug, the drug acts for around 6 to 8 hours. But as the disease progresses, in the same patient, the drug may start acting for a shorter duration. That means when you give this drug to a patient who has had Parkinson disease for, let's say, 5 years or 6 years, initially he or she may be showing very good response to levodopa, but 3 4 years down the line, what happens is that the response keeps coming down. So initially the patient would have seen the benefit for around 4 to 5 hours, but later on they see that improvement only for 2 hours. After 2 hours, they again start having those symptoms. So we need to keep increasing the frequency of the drug administration. That is called wearing off effect. And they can also have on and off episodes. On episodes are basically because of side effects of levodopa. Levodopa can cause certain side effects like dyskinesias, which are more when the dose of levodopa in the blood is at the peak. So these are called peak dose dyskinesias. Or sometimes they can have off episodes also. That is, off is when enough drug is not there in the body, they start showing their Parkinsonian symptoms. So wearing off effect, delayed on or no on, or early off. That is, they start developing their off symptoms very early in the disease. Or sometimes they can have something called dopamine dysregulation syndrome, where they start taking more and more levodopa. They get addicted to the response that they get, and they start taking more and more tablets, and this leads to side effects also. So what are the common adverse effects of these drugs? Anorexia, nausea, tachycardia, hypotension, and sometimes psychiatric abnormalities. Coming to dopamine receptor agonists, these are another class of very useful drugs. Ergot derivatives which were used previously are not used now for Parkinson disease. We mainly use non-ergot derivatives like pramipexole, ropinirole, rotigotine, or apomorphine. They are used as monotherapy or in addition to levodopa. Rotigotine is also available as a transdermal patch, and apomorphine is administered using a continuous subcutaneous infusion. So this can be given parenterally. But now these days we also have sublingual apomorphine, which can be given to the patients, and they see rapid response in their symptoms. So again, coming to side effects, they have similar side effects, but sedation is more prominent. Psychiatric features like cognitive impairment, hallucinations, confusion are more prominent with dopamine receptor agonists. So that's why we need to be cautious in elderly patients and in patients who have uh, psychiatric abnormalities or cognitive dysfunction. In them, we need to be very cautious before prescribing dopamine receptor agonists. Some other drugs that are helpful are monoamine oxidase B inhibitors. So the commonest examples are selagelin and rasagelin. These also have a disease modifying effect on Parkinson disease. So what they do, again, their action is similar to carbidopa. So they prevent the metabolism of levodopa. So they make more of levodopa available to reach the central nervous system, and then the effects of levodopa can be uh, enjoyed by the patient. Similarly, COMT, catechol O methyl transferase inhibitors. Examples are entacapone and tolcapone. Tolcapone is not used anymore because of severe hepatotoxicity reports. So entacapone is still available. What it does is it reduces the off time and it prolongs the on time. Again, the mechanism is similar. They prevent the metabolism of levodopa. More levodopa reaches the central nervous system. This summarizes the metabolic pathways involved in levodopa. Other drugs rarely used, or they are partly effective. They may not be very effective, but in some patients, selective patients, they can be effective. That is amantadine. It's an NMDA receptor antagonist. It was initially discovered as an antiviral agent, but then it found its use in Parkinson's disease also. It is mainly to prevent dyskinesias associated with levodopa therapy or the Parkinson's disease itself. Side effects could be livedo reticularis, weight gain, or cognitive impairment. So, in addition to the motor manifestations, non-motor manifestations also need treatment. Like for depression, we need to give them antidepressants. Some patients need antipsychotics. And in case of orthostatic hypotension, we need to give them drugs like midodrine or fludrocortisone. Or some patients with sexual dysfunction also may need medication like sildenafil or tadalafil. Or constipated patients may need laxatives. Or some patients can have diarrhea. In them, we need to give anti-kinetic drugs, anti-motility drugs, basically. Sorry. So, is only medical management the treatment of choice? Initially, yes, but there are surgical treatments also. Initially, historically, palliadectomy used to be done, which is no more a treatment modality in these patients. But the most important surgical treatment that is currently available is deep brain stimulation. We selectively we screen these patients, and basically there are multiple factors that we need to take into account because not all patients can benefit with deep brain stimulation. There are very stringent selection criteria. We use those criteria, and then if we find that the patient can benefit from DBS, we subject them to that. Basically, they place electrodes in the brain which are constantly stimulated at frequencies that can be changed, and the commonly stimulated structures are globus pallidus or substantia nigra or subthalamic nucleus. So there are electrodes placed, and then there is a transducer where the settings can be changed depending on the patient's symptoms. The patients themselves can change the symptoms depending on the response. Or rarely, they can have a continuous intraintestinal infusion of levodopa and carbidopa. This is called duodopa. So that summarizes the treatment for Parkinson disease. What could be the differential diagnosis? Sometimes you may mistake some other disease for Parkinson's disease. So these could be atypical Parkinsonism, drug-induced Parkinsonism, genetic Parkinson disease, or a Parkinson plus syndrome like PSP or MSA, multiple system atrophy, or sometimes essential tremor. A patient presenting to you with tremor, unilateral tremor, can actually be a patient of essential tremor. The patient may not have rigidity, bradykinesia, or other features. It could simply be just essential tremor. A thorough clinical examination will be really helpful in diagnosing these other conditions and differentiating them from idiopathic Parkinson disease. So there are certain red flags which you can use to because these red flags are not the typical features of Parkinson disease. For example, no response to levodopa, early onset of falls or postural instability, or early onset of dementia, early onset hallucinations, delusions, which are seen in Lewy body dementia, lower half Parkinsonism, which is seen in normal pressure hydrocephalus, or some patients can have cerebellar signs which are usually not seen in Parkinson disease, or bilaterally symmetrical onset, absence of tremor, or pseudobulbar palsy. All these features are again the diagnosis of Parkinson disease. There is a scoring criteria for Parkinson disease patients. This is basically this is a list of criteria that are there which takes into account all both the motor as well as non-motor manifestations. When we have patients, we start screening them, we start scoring them using this UPDRS criteria. And then why do we do this? Why do we need to do this? Is to monitor them basically, to know whether they are progressing or whether they are static or if they are really improving. To know this, we every time they present to us on each visit, we do their UPDRS scoring, and then we see whether the medication or the non-pharmacological treatment that we are giving is actually helpful to the patient or not. So there are certain features which are supportive for the diagnosis. All the clinical features that we have described during the entire session, or they are like unilateral onset, rest tremor, progressive disorder, and good response to levodopa, and levodopa response remaining constant for 5 or more years. All these features are supportive of a diagnosis. So coming to the physiotherapy aspects of Parkinson disease, what is the importance of physiotherapy for a patient who is suffering from Parkinson disease? Is that the of late, recent studies have demonstrated that aerobic exercise or exercise for that matter can even have disease modifying effect in Parkinson patients. So basically regular exercise can even slow or stop the progression of Parkinson disease. In addition to that, we mainly aim at maintaining their functional independence, and physiotherapy should help them in muscle strengthening, their posture correction, and prevention of imbalance and prevention of falls. We need to devise strategies where they do not fall, and our attempts are to mainly see that the patient remains independent and mobile for as long as possible in the disease course. But once the disease advances, probably passive physiotherapy and probably providing them with assistive devices, all these things are like for supports basically. So all these things can be helpful in patients with Parkinson disease. Some of these details have been discussed in the sessions on Parkinson disease, but this is the brief outline of how we deal with patients with Parkinson disease. Thank you for your patient listening. I'll be happy to discuss any doubts if any of you have. I'll wait for a while. In case any of you have any doubts, please feel free to ask.
Sir, no questions asked, sir.
Okay. So should we wait for a while?
Yes, sir. Sir, there is a question asked. I'll just send WhatsApp you the question.
Okay. So the question is that how can we assess a bedridden patient? So this is this is a not an uncommon scenario that we face. We are usually asked to consult a patient who's been bedridden for a while. So there our diagnostic the quest for diagnosis basically it starts there. We need to diagnose what the problem is, what has resulted in the patient being bedridden. So for that, we might need to go back into their, go back by probably 5 or 10 years. Usually in Parkinson disease or Parkinsonian plus syndromes, the history dates back years. So the patient may not have become suddenly bedridden. So it would have taken them some time to reach that stage. So before becoming bedridden, what were the clinical features that we need to, go deep into? And then after that, there are certain examination findings where we need to examine the patient also. See, we need to look for both motor and non-motor manifestations like reduced blink rate or rigidity, whether it is symmetrical or asymmetrical, and whether they have any postures, whether they have rest tremor, whether they have limb rigidity and axial rigidity also. So after all this, thoroughly evaluating the history, the clinical examinations, and if the patient has investigations also, then we should first come to a conclusion, to a diagnosis. So for example, if we think that this patient has a Parkinson disease, and the patient is bedridden because of Parkinson disease, we need to make sure whether the patient has got enough pharmacological treatment or not. So if a patient who's bedridden, who's suffering from Parkinson disease, was never started on levodopa therapy or was not given adequate doses of levodopa or dopamine agonists, so that we need to ascertain, because in such cases, once we optimize therapy, the patient who was earlier bedridden may start walking. We've seen such cases, patients being totally bedridden for a few months. Then we diagnose Parkinson disease, we try levodopa therapy, they start walking. And but the other scenario is if the patient has already been on treatment and is bedridden because of the progression of disease, then it becomes little difficult. So in such cases, we need to concentrate more in terms of prevention of disability and prevention of complications like bed sores and infections like aspiration pneumonia or urinary tract infection. And passive physiotherapy is what we can do, so that the patient does not have rigidity, to prevent rigidity and contractures and to improve limb movement. So I think this is how we need to approach a patient who is bedridden.
Sir, I have texted you one more question, sir.
Okay, let me check that. I think it's asking about management of stage 5 Parkinson's patient. So I think it is similar. Stage 5 is a patient who is bedridden. So in them, we have pharmacological therapies, and then the surgical techniques that we have described, like for example, the deep brain stimulation, unfortunately, is not very effective in advanced Parkinson disease. So in advanced Parkinson disease, there are, in fact, we are waiting for a really good treatment that will help them out. So in advanced PD, it is mainly the symptomatic therapy. Basically, we need to look at what complications they're bound to develop and treating them. For example, as I said, we need to prevent infections. Infections are the most common complications. Along with that, severe PD patients can also have swallowing difficulties. So nutrition has to be taken care. For that, temporary measures like an nasogastric tube can be placed, or a permanent solution like a percutaneous endoscopic gastrostomy has to be done. So nutrition has to be taken care of. Basically their infections have to be controlled, and then there anyway physiotherapy has to be done to prevent rigidity and prevent bed sores, all this. At the same time, their fluid status, nutritional status also has to be maintained. We need to see if they are having any dysautonomic features. Dysautonomic features could be hypertension, tachycardia, bradycardia. So we need to carefully assess for these, and if required, we need to put them on medication. For example, patients who have postural hypotension, in them we need to add drugs like midodrine. Or some patients can have constipation, so their gut motility is impaired, so we need to give them drugs to promote their gut motility. Basically, once it is advanced, all the treatment is more of supportive care rather than anything that is disease specific.
So that's all, sir. No other questions are asked.
Okay. So should we end the session?
Yes, sir, you may end the session.
Okay. Thank you all. Have a good night.